I'm Dr. Susan Merrill. I'm a general internist and geriatrician practicing at the University of Washington Medical Center. I'm going to be talking about some key principles in geriatric medicine. The objective of this brief vodcast is to describe 3 principles of geriatric care, highlighting pearls that may be relevant to multiple clerkships as well as your shelf exam. After this first vodcast, you should do a brief case exercise, which I will explain at the end of this talk. Then you'll watch the second vodcast, which will review the cases. So what's different about the older patient? How are Statler and Waldorf on the left different from Bird and Ernie on the right? There are numerous physiologic changes with age, even in healthy older people. 80% of patients over 65 have at least one chronic illness, and about 50% have 3 or more. Many have functional disability, which has a big impact on their lives and must be taken into consideration in any treatment plan. Older patients are also more susceptible to iatrogenic and adverse drug events than younger patients. Just a reminder here of some of the physiologic changes of normal aging. For example, in the heart, there's a decrease in the number of myocytes and autonomic tissue. This causes decreased ventricular compliance and fibrosis of the conduction system, leading to an increased risk of hypertension, diastolic heart failure, and arrhythmias. In the lungs, there is a decrease in chest wall compliance, lung elasticity, and mucociliary clearance, leading to an increased risk of pneumonia. In the kidneys, there is sclerosis of nephrons and decreased blood flow, causing a fall in GFR of about 45% by age 80, leading to an increased risk of acute kidney injury and drug toxicities. A geriatrician named Morton Creditor coined the term cascade to dependency to describe the difficult set of circumstances facing older patients who are hospitalized for acute illness. The physiologic changes of usual aging and the increased burden of chronic illness interact with acute illness as well as environmental factors in the hospital when people are confined to bed to cause functional dependence. This is why so many older patients who are living independently end up in a nursing home after even a brief hospitalization. We want to do everything we can to prevent this cascade to dependency to preserve the independence of older folks in the community. This is my great Uncle Joe, who lived to 103 with a great degree of independence. He lived in Santa Monica, where he met some Hollywood types, so he was even on Instagram. I wrote an article with some colleagues detailing 10 ways to improve the care of older patients in the hospital. Here I'm going to simplify this down to 3 principles. They are as follows. Number 1, prevent geriatric syndromes. Number 2, assess and maintain functional status. And number 3, avoid polypharmacy. A geriatric syndrome is a multifactorial condition occurring in the elderly which can result in damage across multiple systems and has significant effects on function and quality of life. They are common but not inevitable with aging and can be treated with multifactorial interventions targeting risk factors. The 3 important geriatric syndromes you should be familiar with are falls, cognitive impairment including delirium, and urinary incontinence. One example is falls. Over on the left is a picture of me. I'm probably older than you, but not very old. If I fall, it's a medical event. I am relatively unlikely to fall, and if I do, it is probably caused by a single problem, something like trauma or cardiac syncope. A traditional medical workup is pretty likely to find one cause amenable to treatment with a traditional approach. On the right is great Uncle Joe in his late 90s. In someone like him, a fall should be considered a result of a geriatric syndrome. An older person is more likely to fall, and the results are usually multifactorial. They have poor vision, impaired balance, an increased risk of orthostatic hypotension, and may be on medications which increase their risk of falling. In an older person, an extensive traditional medical workup for a problem resulting from a geriatric syndrome may sometimes be appropriate, but is more likely to be unrevealing, reveal pathology that is of uncertain significance, and lead to iatrogenesis. The best treatment approach for a problem caused by a geriatric syndrome is multifactorial risk reduction. The second principle of care of the elderly patient is assessing and maintaining functional status. Functional status is basically the ability to care for oneself and is measured by the ability to perform activities of daily living, abbreviated as ADLs, and instrumental activities of daily living, abbreviated as IADLs. Knowing an elderly patient's functional status is essential to developing an appropriate care plan. It's been shown to be quite predictive of a patient's prognosis. For example, older patients who cannot complete their own activities of daily living are at higher risk of readmission after a hospitalization and even death. A brief geriatric assessment should be completed periodically for older people in clinic and for most hospitalized older patients. This includes the following: questions about whether the patient can complete their ADLs and IADLs. ADLs are necessary for fundamental functioning and can be remembered as what you needed to be able to do to go to kindergarten: dressing yourself, bathing, transferring, feeding yourself, and using the bathroom. IADLs were what you needed to be able to do in order to go to college, things like managing money, grocery shopping, and managing transportation. Other important elements of a brief geriatric assessment include a complete social history, a brief cognitive assessment, and a physical and occupational therapy assessment for most inpatients. The third important principle is avoiding polypharmacy. This is the use of more drugs than is clinically indicated. The risks include an increased risk of adverse drug events, an increased risk of inappropriate medications, decreased adherence, and an increased risk of falls and cognitive impairment. There are multiple causes of polypharmacy. Many older patients have multiple chronic illnesses for which they may be prescribed medications, often according to clinical guidelines. Some older patients visit multiple subspecialists who may not communicate well or know the patient's complete medication list. Patients sometimes prefer pharmacologic solutions to problems rather than lifestyle changes or interventions like physical therapy. There's also something called the prescribing cascade. The prescribing cascade is the phenomenon in which a patient is prescribed a new drug and develops symptoms from an adverse drug effect which are misinterpreted as a new medical condition. The patient then is prescribed a new drug for these symptoms or self-treats with an over-the-counter agent. For example, a patient might be prescribed a non-steroidal anti-inflammatory for pain and then develops hypertension as a side effect, for which he or she is prescribed an antihypertensive. The prescribing cascade should be avoided whenever possible. There's a very helpful resource to aid in appropriate prescribing called the Beers Criteria, named after Dr. Mark Beers. It's an evidence-based list of drugs that may be inappropriate in the elderly or with certain conditions, which was last updated in 2015 and is intended to be used as a guide for risk-benefit discussions when prescribing to elderly patients. Now it's time to practice some of the principles I've just discussed. Go back to the website and pick one of the case exercises. Case 1 is an inpatient case, and Case 2 is an outpatient case. Each case has a worksheet with a case and 3 questions, as well as some supplemental material you'll need to use to answer the questions. Feel free to do both cases, of course, but please do at least one before clicking on the second vodcast. I'll discuss the answers to both cases there. The students in the classroom in Seattle had 15 minutes to work on this. You should give yourself about the same amount of time.